So we're here with Interpace, and it's a diagnostic for the evaluation of pancreatic cystic lesions. And we find these lesions not uncommonly, and diagnosis tend to be challenging. In addition to cytology and the CEA level from the pancreatic cyst FNA, molecular testing have really taking our diagnosis up to the next level. And with Interpace, molecular analysis of pancreatic cystic fluid, we're able to look at biomarkers with KRAS mutation, GNAS, LOH mutation, as well as DNA quality and quantity. And we get a fairly accurate assessment, and we have looked at outcome of these lesions after diagnostic testing with molecular analysis. And it's fairly simple. After the FNA of the pancreatic cyst, we take a small amount of fluid and we send it to Interpace. The turnover is approximately 2 weeks, and it is covered by Medicare and most payers. So it's really a seamless process where the patient doesn't have to worry about the financial part of it. Anything you want to add, John?
Yeah, I do. So one of the things that most physicians, including Dr. Wynn, really appreciate, I think, with Pancreagen is we're able to stratify the risk of the potential lesions on a continuum. And we colored this like a common street light, green, yellow, orange, and red, where when you see a benign or a statistically indolent result from us, you know that you have around a 97% chance of that lesion remaining benign or indolent for a period of 2 to 3 years. When you move into the high grade and aggressive areas, it changes it significantly. You have a 65% chance that, or probability that you're going to have high grade dysplasia, and if it's aggressive, it's a 91% chance. So these patients on this side of the algorithm oftentimes end up being referred to surgery for potential resection evaluation of, the pancreas, either a Whipple or a pancreatectomy. So it is really a wonderful prognostic tool. Unless you're actually pulling out a solid specimen or biliary stricture, then it becomes more of a diagnostic tool, because we don't give you this stratification of risk on this continuum anymore. We give you a binary answer. So it's either malignant or benign, period. So it's a wonderful tool for that, from that perspective, because it's able to move with respect to what you're sampling.
How much fluid does it require?
That's a very good question, Dr. Kinsey. The minimum amount of fluid we like to receive is 0.2 ml or 200 microliters, but we'll take as little as you can give us. In fact, the sample tubes are this size, and I've received samples from many physicians where there's literally just a drop in here, and we'll still be able to test it. We'll still be able to run molecular. We'll still be able to run even fluid chemistry on it as well. So that's a great question.
Does it need to be refrigerated?
It does not need to be refrigerated. We do have some ice blocks in our kits, and that's just to keep the stability of the specimen at a particular room, not a room temperature, but a range temperature, while it goes into transit to Pittsburgh, where we test it.